Welcome to Pulse and Pressors, where critical care gets crystal clear. Vecuronium is an aminosteroid neuromuscular blocker with a highly stable hemodynamic profile. It provides smooth paralysis without histamine release and offers intermediate onset and duration. However, because it relies on both hepatic metabolism and renal excretion, its pharmacokinetics become significantly altered in critical illness. Its active metabolite, 3-decacetyl vecuronium, is often as potent as the parent drug and is a major contributor to prolonged paralysis in ICU patients. Vecuronium is a non-depolarizing competitive antagonist at nicotinic acetylcholine receptors. It prevents acetylcholine from activating the postsynaptic muscle membrane. This results in flaccid paralysis without depolarization and avoids potassium shifts or fasciculations. This mechanism gives vecuronium a safe profile in patients where succinylcholine is contraindicated. The drug undergoes hepatic metabolism and is eliminated through biliary and renal pathways. Its active metabolite, 3-decacetyl vecuronium, is as potent or more potent than the original drug and accumulates significantly in hepatic or renal dysfunction. This leads to unpredictable recovery times, especially in ICU patients on prolonged infusions, making metabolite accumulation a defining clinical consideration. Vecuronium's ED95 of approximately 0.05 milligrams per kilogram reflects its high potency compared to other paralytics. Despite this potency, its onset is slower than rocuronium, making it less desirable for rapid sequence intubation. Its duration varies significantly in the presence of organ dysfunction, which must be considered when dosing. The typical onset is 2 to 3 minutes, and duration is between 45 and 75 minutes. In shock, poor hepatic perfusion slows metabolism dramatically, prolonging effects. Vecuronium also accumulates rapidly during long-term infusions, leading to prolonged neuromuscular blockade long after the infusion is stopped. Vecuronium has minimal cardiovascular effects and virtually no histamine release, making it a stable paralytic for most patients. This hemodynamic stability is a major advantage in anesthesia and controlled ventilation settings, particularly for patients who cannot tolerate fluctuations in blood pressure. Dosing includes an intubation dose of 0.08 to 0.1 milligrams per kilogram, maintenance doses of 0.01 milligrams per kilogram, and infusions of 1 to 2 micrograms per kilogram per minute are common. Because the drug is metabolized and excreted via both liver and kidney, adjustments are necessary in hepatic or renal dysfunction to avoid dangerous accumulation. The active metabolite 3-decacetyl vecuronium is responsible for significant clinical issues in critical care. It accumulates in renal failure and hepatic dysfunction and can lead to prolonged paralysis even when standard doses are used. Recovery becomes unpredictable, and awakening may be significantly delayed despite stopping the infusion hours earlier. Vecuronium is suitable for operating room intubations, controlled mechanical ventilation, and settings where the onset of paralysis does not need to be immediate. It is also a safe alternative when succinylcholine is contraindicated, such as in hyperkalemia or neuromuscular disorders. The drug should be avoided in severe hepatic or renal failure because of its dependence on these organs for clearance and the accumulation of its metabolite. It is also less desirable when long-term paralysis is required, as cisatracurium offers far more predictable clearance in critical illness. Vecuronium is potentiated by aminoglycosides, magnesium, calcium channel blockers, lithium, and beta blockers. Chronic anticonvulsant use increases resistance. These interactions are especially important in ICU settings where polypharmacy is common and patients often receive magnesium infusions or aminoglycosides. In critical illness, vecuronium becomes difficult to manage. Sepsis, multi-organ failure, hepatic congestion, and renal injury prolong its action dramatically. Infusion use leads to accumulation and unpredictable awakening. ICU patients may remain paralyzed long after expected recovery because of metabolite buildup. Vecuronium can be reversed with neostigmine and glycopyrrolate. Sugammadex is highly effective for reversing vecuronium because it encapsulates aminosteroid paralytics. Depth of blockade determines Sugammadex dosing. Vecuronium should not be redosed immediately after Sugammadex because the reversal agent will bind and inactivate it, causing ineffective paralysis. Vecuronium remains useful in operating room environments where patient physiology is stable and organ function is intact. It works well when slower onset is acceptable and hemodynamic stability is prioritized. It should be selected carefully in patients with normal hepatic and renal function. Vecuronium is a reliable paralytic when used appropriately, but requires expert understanding of its metabolism, active metabolites, and accumulation risks. In critical illness, alternatives such as cisatracurium are superior because of predictable clearance. Vecuronium demands precise dosing, active monitoring, and careful patient selection to avoid prolonged paralysis. This is Pulse and Pressers, reflecting on the marvels of the human body. Subscribe to stay sharp.